Chairpersons, over to you to conduct the Endocrine Symposium.
Okay, welcome to after the lunch. We'll come to the next session. So this is regarding our endocrinology quiz. So I would like to call Dr. Uditha Bulugahapitiya to the stage. This is regarding neuro-oral hypoglycemic and insulin therapy for better glycemic control of diabetes. It's a Q&A panel. So if you have any questions, please, there are mics. I suppose you have been giving some mics. So then you can ask any questions because Dr. Bulugahapitiya, who is give the introduction. Dr. Bulugahapitiya is a renowned consultant endocrinologist at the National Hospital, Colombo. He is the current chairperson of the specialty board in endocrinology at Postgraduate Institute of Medicine. Dr. Bulugahapitiya was the founder president of Sri Lanka College of Endocrinologists. He has over 100 publications in reputed local and international peer-reviewed journals and has been honored with many fellowships and awards for his work in endocrinology and diabetes. Dr. Bulugahapitiya was bestowed with highest national honors, Desha Manya, in 2019 in recognition of his contribution to the profession and nation. So he is the ideal person to give you the answers of your questions. So now it is open for you all. You can ask questions. He is there to answer regarding our topic, neuro-oral hypoglycemic and insulin therapy for better glycemic control. Okay, it's over to you all. You can ask questions now.
Please show a raise of hand if you have any questions.
Can we cure diabetic if we start a treatment for that very early stages?
Yeah, actually the term you used is the cure diabetes, but the term that we like to use is the remission in diabetes remission. Now, if you have a patient who has got type 2 diabetes with insulin resistance, and many studies, especially direct study and other studies have shown that there is a temporary reversal of the disease, sometimes for 2 years or more than 2 years sometimes. So the fact there is that you need to start treatment early, and there is, most of the studies have shown about 8 to 10% of weight reduction is necessary. So probably they need about early nutritional care to do that, 8 to 10%, at least 10 kilos of weight reduction. If somebody can do it, then you may not be able to treat them with any medications. But we don't say it as cure, but it's a diabetes remission. In patients with bariatric surgery, it's shown very well that about 70% of the patients who undergo bariatric surgery has a remission in diabetes because of various reasons. Not only the weight reduction there is usually things happening in the gut, especially the gut microbial and the other incretins in the gut. Shows that there is a remission in diabetes. But whatever you say, but when you reduce weight, the question that you as general physician should ask from the patient is, are you hungry? If the patient is hungry, and if you try to reduce weight to at least 10 kilos, in next 3 months the patient is going to get the same weight or more than that. So question, if the patient is hungry, that means your weight reduction protocol is somewhere wrong, and you need to rethink about and revisit that.
Add that if the weight is normal, at the presentation, so how would you do that?
Question is that if the patient's normal BMI and weight is normal, can we think of curing diabetes? Still it's possible, because even if you think about 5 to 8% weight reduction from the basal weight, BMI, still it's possible. We have shown in the bariatric surgery, when the patients are having more than 100 units of insulin, with a normal BMI, we have gone through the bariatric surgery, and patient is completely on remission for years and years. So that has been shown even in the patients newly diagnosed diabetes with weight reduction even below the normal level. We know that Asian BMI cutoffs are like 23. 23 is the normal. So from 23 onwards, the metabolic parameters will go in the wrong direction. Therefore, I think it's important. And also, the central obesity is extremely important in the Asian countries when you compare with other countries. We know that if you look at the European people, their central obesity is very less. But when you come to the Asian population, central obesity is the problem. And 90 centimeters for male and the 80 centimeters for female is the waist circumference. I think as a general physician, what you can easily do is that height, weight, BMI, and the waist circumference, and give an insight to the patient that your BMI is too much, and you can easily calculate the ideal body weight for the patient and say that you at least try this. But that depends on the basal weight of the patient. If you are looking at a patient who is 100 kilos, you will never ever even think of getting into a normal weight. Therefore, when you have a higher weight, there is something called clinically meaningful weight loss. It's about 5 to 10% of the weight from the basal weight. So anybody who has more than 100 kilos or more than 90 kilos, you are only looking at a clinically meaningful weight loss. That is about 5 to 10% of the basal weight.
Good afternoon. Actually, this question is one of my observations. Actually, some patients I have seen, they are on very high insulin, but at the same time they are taking sulfonylurea, sitagliptin, a lot of other drugs also with very high insulin. So practically pancreas is apparently not functioning with very high insulin, but still the doctors used to give other sulfonylureas and other sita and all that on top of that. Does it serve any purpose? That's one question. And the other one is that I would like to know the fashionable drug GLUT2 inhibitors because they are used in diabetic patients. The commonest complication is the diabetic, the renal problems. CKD also comes with the long-term diabetes. So how do you tail off or the balance this GLUT2 inhibitors depending on the CKD level? The second question.
Right. I think the first question I'll ask you first. Now, patients who are on insulin, what can you combine with insulin? Actually, now when you start insulin, that means your beta cells are dysfunction to a great extent. When you start diabetes, when somebody has a newly diagnosed type 2 diabetes, that means your roughly 50% of your beta cells are not functioning. That's why we say there is nothing called mild diabetes or a moderate diabetes or a severe diabetes. When you get diabetes, your 50% of your beta cells are not functioning. So what happens, you start with medication with oral and you go on for some time and continuous deterioration of the beta cells happen with time. And there are certain medications will protect beta cells more than others. We'll discuss it if somebody asks that question. But what happens is when you start insulin, you must understand there is very limited beta cells function still available to secrete insulin, like about 5 to 10% maximum. Now when that happens, the continuation of the sulfonylurea has a minimal benefit. So I think that's not a cost-effective thing to do that. Therefore, get the sulfonylurea completely out. If you're on a twice-a-day insulin, I'm not talking about once-a-day insulin. If you're on a twice-a-day mixed insulin, you can take complete out sulfonylureas. You can keep metformin because it acts on a different pathway, because it's reducing your insulin resistance and so on. That's fine. You can continue sitagliptin because sitagliptin is acting on the DPP4 receptor. So it's a different completely pathway. But it's costly. That you need to understand. If you already continue sitagliptin, it's costly. Then if you come to SGLT2 inhibitors, you can continue the SGLT2 inhibitors because it's completely a different pathway it acts. Because it acts by taking glucose out of your bloodstream. So therefore, you can easily continue the SGLT2 inhibitor. So what I suggest is that if you're on a twice-a-day mixed insulin for a diabetic patient, you can continue sulfonylurea, you can continue metformin, you can continue sitagliptin, you can continue SGLT2 inhibitors. And I think when the patient is on insulin, the question that you asked every time when the patient comes is, you look at the HbA1c. If the HbA1c is okay, you have to look at the patient's weight. If the patient is gaining weight, that means you are in a wrong direction. You need to rethink and reduce your insulin because patient is getting actually asymptomatic hypoglycemia and patient is eating and weight is gaining but HbA1c is fine. That's a one scenario. So if you're gaining weight, that means you're in the wrong direction. You need to think twice and reduce your insulin doses. But sometimes you can have a very high insulin doses, HbA1c is 10, and you again and again and again you increase your insulin dose. What is happening there is that patient is very hungry, patient is eating continuously, you are increasing your insulin, increasing the appetite, increasing what you eat, and you are nowhere of your HbA1c. So if the patient is gaining weight with a poor HbA1c, that means again you are in the wrong direction. You need to reduce your insulin doses rather than increasing your insulin doses, and keep your meals properly in order to treat that. I think the other question is that if you're on a once a day insulin, which is a very good option actually. Now when you all start insulin, I don't think that you can go directly to the twice a day insulin. If a patient on a maximum oral medication, that means maximum oral medication, not the doses actually. The maximum metformin dose is 850 twice a day. You should not go more than that. That is the clinically meaningful dose. And then glycoside is 160 twice a day, sitagliptin is 100. When you're on 3 medications and if you're unable to get HbA1c less than 7 or around 7, then there is an indication for you to start the insulin. So you can start insulin as a once daily insulin. That's a long-acting basal insulin. You can have a human insulin or analog insulin. You can start at bedtime as a once daily insulin, which is acceptable for many patients, because patient will need not to actually plan for the meal if you're on a basal insulin. Basal insulin is very easy because you just take it at bedtime. You start the basal insulin, then you continue the sulfonylurea, metformin, sitagliptin, whatever the oral medication, and start with the basal insulin, and ask the patient to do blood sugars, only the fasting at home or glucometer, and try to titrate it every 5 to 6 days up to the 90 to 130 range of fasting blood sugar. When that comes to the range, you are 90% of the time your HbA1c is on the target after 3 months. So when patient is on oral medication plus basal insulin, you can go for about 2-3 years like that. But question is when to start the once daily insulin and when to start twice daily insulin. When a patient's HbA1c is more than 10.5 with a maximum oral medication, no point of starting once daily insulin. That is beyond once daily insulin. That's the target. So if your HbA1c is more than 10.5 with a maximum tolerable doses of oral medication, then you need to think about twice daily insulin. So you start twice daily insulin straight away. So that's how you differentiate. When you're on a once daily insulin, if your HbA1c is failing, that means HbA1c is not at 7 or less than 7, then you look at the fasting blood sugar. If your fasting blood sugar is at the target, and if your HbA1c is not at the target, that means the basal insulin cannot be continued, because there is no functional reduction of HbA1c after that. So those are the indications for once daily insulin to go into twice daily insulin. And also when the patient is on insulin, twice daily insulin, always patient has to fix the meals. Because if you're on a human insulin, half an hour, 20 to 30 minutes prior to the meal, you have to take the insulin. If you're on analog insulin, you can just, with the meal, you can have it, or 10 minutes after the meal, you can have it. But the lunch is always fixed. Now, if you are taking the insulin around 6 to 8, your lunch should be around 12:30 to 1:30. You can't have 3 o'clock lunch. Therefore, if you are treating a schoolboy who goes to school around 6 o'clock in the morning with a mixed insulin, he can't come home and eat at 4 o'clock. He's going to get a hypoglycemia. So you need to rethink about and what the job and everything when you start insulin for these patients.
Twice a day insulin means like pre-mix, I suppose.
Yeah, twice a day insulin is pre-mixed, 30-70 or 25-75. So that's what I was talking about. Basal bolus is actually especially in the type 1 diabetes. But I think if you are going for type 1 diabetes basal bolus, then the patient can't be on a normal diet. Patient should do the carb counting. So before eating, patient should know what the insulin dose that the patient should get it. I think if you are interested, we have the carb counting app and the book. It's not easy, but Type 1 diabetic patient should never get a basal bolus insulin with whatever the patient eats. The carb counting need to be continued with the type 1 diabetes.
The thing is now, majority of I think the crowd is from they are working in the hospitals. Thing is, hospitals, they don't have this, the basal insulins, because they have only pre-mixed. So that's why I think the very practical question is they see patients with high doses of insulin. Still the HbA1c is in very high levels. I think that's the question why they ask a question.
I think in hospital setting, if I see a patient who is more than like 190 units of insulin, I always reduce. Insulin is hugely expensive. People are selling outside the hospital. If you go to almost all these hospitals, in front of the pharmacies, you get the government seal. It is available in the pharmacy. So don't get misled by the patients. When you know that the patient can't use more than 100, only about less than 2% or 1% can have more than 100 units. So don't get out of by that. So reduce the dose, get the patient to exercise, diet properly, and make sure don't use more insulin. If you don't have a basal insulin, you can use a mixed insulin at night. When you use the mixed insulin at once the dose at night, you can even use it half an hour before dinner, or even bedtime is fine. There is no problem. You can continue like that.
Sir, when switching between the insulin preparations, how should the soluble insulin dose be converted to mixed insulin?
That's actually now, if the patient is in a ICU setting kind of a thing, when you treat the patient's ICU setting, you actually give an insulin infusion. When you want an insulin infusion of ICU patient, your target at ICU is 140 to 180 milligrams per deciliter all the time throughout the 24 hours. So when you achieve that 140, 180 target, and the patient is on 3 meals in the ICU, and the patient is ready to get out of the ICU, so you can get last 12 hours total insulin dose that you have given to the patient, and then 24-hour insulin requirement. From that, you get 80% of the insulin to the basal bolus or a mixed insulin. That's how you actually get into that. So 80% of the total dose you can have, if you are going for basal bolus, 50% basal, 50% bolus. If you want to directly get into the mixed insulin, 80% you can, the way that the patient is eating, you can have more in the morning, less in the night to avoid hypoglycemias.
Sir, what are the potential risks or complications associated with long-term insulin therapy?
Insulin is actually a very good medication. Insulin is energy. Now, when there is one way that you can understand, how do you decide that this patient needs insulin? One thing is that poor HbA1c with a high, poor HbA1c with the maximum oral doses. Other important point is if somebody is losing weight with good HbA1c, that means insulin is deficient. Somebody is losing weight with a good HbA1c, that means insulin is deficient on that patient. Because insulin is energy, that majority of the, if you look at the Olympics and so on, majority of the sportsmen, they actually use insulin, short-acting insulin, get the power. Because insulin is energy. So you need to understand that point. Insulin is actually cardiovascular neutral. There is no cardiovascular protection, there is no cardiovascular advantage, but there is no cardiovascular worsening outcomes. Therefore, insulin is extremely safe. Whenever you insulin start on a patient, should not tell the patient that you are in a critical situation of diabetes. Nothing like that. It's a stage of diabetes. You start with oral medication, and there's a stage of diabetes that patient will not control with the oral medication. There's nothing called severe diabetes at that point. It's just a diabetes, but you can easily control it. Insulin. Insulin is cardiovascular neutral, and there's no worsening. But the problem is, whenever you use insulin, the patients can go into hypoglycemia. I think you must avoid all the hypoglycemia. Hypoglycemia is the one major cardiovascular risk factor and increase the cardiovascular risk and the heart attacks and so on. So hypoglycemia should be avoided whenever you use insulin. That's the way forward. I think you should know all the medications which causes cardiovascular protection. Metformin, there are for and against, and majority of the people now believe that there is no much of evidence for the cardiovascular protection, but still you can see there's some protection. sulfonylureas, cardiovascular neutral, and then sitagliptin, 100% cardiovascular neutral. So when you spend 100 rupees or 70 rupees for a sitagliptin, think twice, because HbA1c reduction is 0.5%, and you are spending a lot of money without any cardiovascular outcome benefit. Then the SGLT2 inhibitors, it's an oral tablet. Cost is around 50 to 60 maximum now, and there is a definite cardiovascular outcome benefit. And it actually, not only the secondary prevention, there's a primary prevention for SGLT2 inhibitors. Therefore, newly diagnosed type 2 diabetes, even SGLT2 inhibitor is important, because if you look at the studies of, not the empagliflozin study, not the EMPARAGE study, but if you look at the others two studies, the dapagliflozin with CANVAS study as well as declatimib 58 shows very clearly not only the secondary cardiovascular disease, but even the primary cardiovascular disease prevention, SGLT2 inhibitors are important. So you have to understand the cost benefit on HbA1c. SGLT2 inhibitors are much better. So then you come into the pioglitazone. Pioglitazone doesn't have much of a cardiovascular outcome benefit, but proactive studies actually shown that about 60% reduction in the cardiovascular outcomes, but not clearly sure. But pioglitazone has still place, even if you look at the ADA guidelines, if you have a stroke, there is a primary and secondary prevention of strokes, the pioglitazone has a place. Therefore, these are the available tablets for us actually. You can think of using it differently. GLP-1 analogs, again good for cardiovascular outcome benefit and also the renal benefit. And SGLT2 inhibitors are cardiovascular outcome benefit, renal benefit, as well as heart failure outcome benefit. So I think if you have that idea of spectrum of medications available for us to use, I think you will use in a correct manner.
Can allow only one question from audience.
Sir, you have told that empagliflozin is a very cardioprotective, and this is now a novel agent used in diabetic. But the problem is that so many patients are complaining of UTI from getting the empagliflozin. Is there any specific thing or specific method to use in that treatment?
If you look at the SGLT2 inhibitor trials throughout almost empagliflozin, dapagliflozin, canagliflozin, everything, there is not a single study has shown there is an increased risk of UTI. There is no increased risk of UTI in almost all the studies. It's a fungal infection of the genital area is the issue. And therefore, when you give the SGLT2 inhibitor, it is important that you give the correct advice. Drink at least 8 glasses of water. That's an important advice. And other advice is whenever you urinate, wash and dry. Those are the two things that you need to do. Not only wash, you have to dry and wipe. Unless you are going to get a fungal infection and getting this problem. Therefore, I think these two are important. So it's difficult certain people to use this because they can't wash. Then you should not use it. And there are certain conditions you have to use them with care. Now, if the patient has single kidney, you have to be careful, because if you have ascending infection with a fungal disease, you are ending up with a major disaster. So single kidney, huge bladder obstructive disease, prostate or whatever, if you get a bladder stasis, that you are going to actually get the more infections and all that. So you have to be careful. And every time when you give SGLT2, you have to say that if you are fasting for any reason, you have to stop the medication. Unless the patient will end up with a euglycemic ketoacidosis, and diagnosis is so difficult that patient will only come and say, "Doctor, I am feeling unwell." And nobody will do anything because patient will feel unwell. Almost all the patients will come and say feeling unwell. And they will die from euglycemic ketoacidosis. Even if you check the blood sugars are normal. And majority of the patients, even the Oxford Center has seen, majority of the patients' unknown deaths due to diabetes are due to euglycemic ketoacidosis. I think you have to be careful, because SGLT2 inhibitor, when you start, the patient is always on a 12-hour fasting state. Every time patient is similar to a patient who is on a 12-hour fasting. You can't fast more. If I am taking SGLT2 inhibitor, I am always on a 12-hour fasting state. That's how the ketosis is happening. So you can't do more fasting. You will end up with a ketoacidosis. So, and also 1 day you get about 70 grams of sugar passing with your urine. That is equivalent to about 280 kilocalories. That means about 3 hours exercises, right? Yeah, about 2.5 hours exercises every day. That is equivalent to the loss of calories by SGLT2 inhibitor. I think you have to think about everything when you use this.
The one common question I want to ask about 16 hours fasting is the common, the fashion nowadays. So in such a patients who are in these medications, so what is the advice that we can give them?
Yeah, 16 8-hour fasting is a fashion at the moment, and loads of things are available. But if you look at the real data which is available for us, 16 8-hour fasting is not very evidence-based. The best is the Mediterranean diet, which you and I should try and eat. That is the best available data for diet. Now, 8 fasting, people eat everything most of the time, and 8 hours fasting, then actually you are creating this ketosis. That's the similar like SGLT2 inhibitor. When you're on a SGLT2 inhibitor, you are actually on a 12-hour fast all the time. So we are trying to create that cycle, which is very transient issue. And if you are on a 8 hours fasting, you can continue the medications like metformin, sitagliptins and things like that. If you're on a glycoside, you have to be careful because they can go into hypoglycemias, insulin. But I think patients who are having advanced diabetes for years and years should not go in this 6-hour fasting. There is no evidence base. Then the keto diet is the other thing that people do it with a high protein diet and a high oily diet, because when you eat cheese and stuff, there are no sugars in that. No problem, blood sugars are controlled, but you are ending up with a heart attack and die with a heart attack with a normal blood sugars. You are taking too many fat. So I think you have to be careful about the diet. The Mediterranean diet is the best evidence-based diet. When you have a meal, try to have about half vegetables in your meal. Quarter you can have rice or any carb. Quarter you can have meat or fish. That kind of a plate is the best for diabetes, and not for diabetes for everybody. You and I think that's the way forward. And do exercise and have the same diet.
The last question: what about the use of GLP-1 agonist and the practice in Sri Lanka currently, and your experience is better to share with the audience?
GLP-1, actually, if you look at all the guidelines, UKPD, all the guidelines throughout the world, it is almost equivalent to SGLT2 inhibitor in terms of cardiovascular risk reduction. So SGLT2 or GLP-1 is the cardiovascular risk reduction, but heart failure, it is SGLT2 inhibitors, not the GLP-1. And when you look at the CKD, the SGLT2 or heart failure, but preferably SGLT2 inhibitor. That's how the scenario is. Now, GLP-1 analogs are tablets as well as injections. The weekly injection is the very commonly used one, even in Sri Lanka. Now it's available actually, although it's not registered. It's available everywhere. So the cost is for a month is about 100,000. And the importance is actually weight reduction. Now, if you look at Ozempic, there's a 1 milligram pen. Although it's a 1 milligram pen, you can actually use about 0.25 weekly for about 1 month. If you go for 2 milligram, it's again about 110,000. You can use for 2 months if you're using 0.5. Because the pen is in such a way that you need not to use the full dose. You can actually click in such a way that you can use 1/4 of the dose. So most of the patients are, if you want somebody to reduce weight, Ozempic or the Wegovy is the higher dose of Ozempic, which is available in Sri Lanka also. But this is now even in Australia. You have to, when a patient you are prescribing a patient, you have to inform the authorities, because this hugely used in obesity, and it's not available in most of the countries in the world because they are misused in the obesity, and it's not available for the use for diabetes.
I think the time is over for questions. Anyway, it is a good brainstorm. They're asking questions and giving good answers because it's a big thing for our audience. And I must thankful to you, Dr. Uditha Bulugahapitiya, for your participation, and you are giving all the supports for our conference.
Thank you very much, sir. And that concludes the panel discussion of the Endocrine Symposium. And I kindly request the chairpersons to give away the certificate and the token of appreciation to Dr. Uditha Bulugahapitiya, and also pose for the photograph. Thank you very much, sir. And we are continuing with the Endocrine Symposium. Next is Navigating Diabetic Nephropathy with Timely Referral by Dr. Udana Ratnapala, Consultant Nephrologist. Chairpersons, over to you once again.
Good afternoon. Let me have the privilege of introducing Dr. Udana Ratnapala. Dr. Udana Ratnapala has been the consultant nephrologist at Teaching Hospital Badula since 2019. He pioneered kidney transplantation, continuous ambulatory peritoneal dialysis, and non-surgical CAPD catheter insertion in Uva province and was instrumental in establishing 6 new satellite hemodialysis units in the country. He is an honorary member of the National Transplant Advisory Council, and he is also the Joint Secretary of Sri Lanka Society of Nephrology. Dr. Udana was awarded with International Consortium for Clinical Research Excellence, Education and Ethics certificate by the PubMed Index Journal. Over to you, Dr. Udana.
Yeah, thank you very much for the kind introduction. Let me first of all thank Dr. Udana Ratnapala, my good friend and of course batchmate, and Dr. Galhera, the president of Sri Lanka College of Specialty Family Physicians, for inviting me to deliver this lecture. Now, I thought that delivering this lecture was a straightforward stroke, but it's not going to be, because it's a Herculean task to speak in front of all your teachers. So here I have got all my kindergarten teachers from the med school, and I have to convince them that I am doing a good job. So, okay, being young is not easy to deliver lectures. Okay, so I'll be starting with the story of diabetic kidney disease. I think Dr. Uditha Bulugahapitiya, once again a teacher of mine, gave a fantastic overview of diabetic management at the primary care level. But let me tell about diabetic kidney disease. Now, diabetes was first, I can see from this, right? So diabetes was first described in 1552, before Christ. And it took 3,000 years to identify the association between diabetes and the kidney disease. But surprisingly, it took only 3 decades, 30 years, for this particular disease to become the leading cause of end-stage renal disease. Now, by judging from my voice, you can see the amount of lectures I have given during last 48 hours. So this is the 4th lecture. I'm coming from Kandalama after speaking in the Sri Lanka Society of Nephrology sessions, giving 3 lectures. So why am I that desperate to give lectures on diabetic kidney disease? The reason is this. If I start counting from there, 1, 2, 3, 4, 5, 6, 7, 8, you are a kidney disease patient. And again, 10. Because the current CKD prevalence in this country is 1 in 10. So out of the audience, we have got at least 12 people having CKD. So I have, there is no chance that I can sleep. I need to go and talk to the crowds and get, prevention for diabetic kidney disease up and running. Okay, so let me navigate the diabetic kidney disease through a case study. Now, this is a patient referred to me, Mrs. X, we'll call her. And she is a 58-year-old lady diagnosed with type 2 diabetes for last 10 years and with hypertension for 4 years and referred due to low GFR. And these were the initial investigations and the findings. So she was a bit on the overweight side. Her HbA1c was not good, 7.5. The creatinine was marginally high at 1.1. And the eGFR, we call it estimated GFR, of 51. Potassium lipid profile looks normal. And what are the medications she was on? She was on metformin, 1 gram twice a day, losartan, 50 milligram nocte, and atorvastatin, 20 milligram nocte. Okay, when I was referred this patient, I was furious. Why? It has taken 10 years to identify diabetic kidney disease, or at least to screen this patient for diabetic kidney disease. As a nephrologist, I am not happy. Because if you look at the basics, let's see how we would approach this patient or any patient with diabetes who and when to screen. So if it is a type 2 diabetes patients, all you should know that patients should be screened at the diagnosis and annually. And for type 1 diabetes patients, it's after 5 years and annually. But there's a misconception among the Sri Lankan doctors to start screening at 5 years in type 2 diabetes, which is entirely wrong. So that's the first take-home message for the trainees, that type 2 diabetes should be screened from the very beginning. The next question is, how would you screen? Now, it is not a big thing to do, so 3 tests. We'll talk about this later on. You should get a simple urine full report. You should get some kind of quantification of protein leak, like urine albumin creatinine ratio, a simple serum creatinine, and estimated GFR. How to diagnose diabetic kidney disease? Once again, it's not rocket science. Let's be very simple in this session. You get an eGFR of less than 60, NO, a urine albumin creatinine ratio of more than 30 milligram per gram, you are having diabetic kidney disease, either O. So, will you diagnose CKD here? If you can remember, from your memory, creatinine was 1.1, eGFR was somewhere around 54, the protein amount was not there, so looks like diabetic kidney disease. But can you rely on creatinine all the time, or eGFR? Now, as practitioners, you should know enough about eGFR. Now, eGFR depends on the creatinine. Now, you have creatinine coming from creatine in your muscle, coming to the body, into the bloodstream, and it gets eliminated through the kidney. So, the production and elimination should be at a steady state because eGFR calculation is a formula. So, creatinine is in the numerator. So, if the creatinine goes up, eGFR goes up. If the eGFR goes down rather. If the creatinine goes down, your eGFR goes up. So, you should be sure that creatinine is at a steady state. Now, in these kind of patients, for example, if the patient is malnourished, having rhabdomyolysis on a low protein diet, creatine supplements or extremes of age, your muscle mass is not stable. In these kind of patients, the eGFR is not reliable. So don't talk to me about eGFR in a patient who has got bilateral amputation. Okay. Then if there's a problem in elimination, don't talk about eGFR. You can't. To talk about eGFR, it should be CKD, stable creatinine, for at least 3 months. So in AKIs and in dialysis patients, for example, you can't talk about GFR. Now you refer me a patient with a change in creatinine in an AKI or in a case of bilateral amputee. How can I know whether this patient has got CKD? Then I have got this test called serum cystatin C, which is fairly expensive when compared to serum creatinine. And the good thing is these confounders won't affect the serum cystatin level. But it has got problems on its own. It varies with steroid ingestion and in thyroid disorders. But as a nephrologist, if I have a problem about creatinine or eGFR, I'll be looking to this new test called serum cystatin C. So much for creatinine. I think it's time to talk about proteinuria. Okay. Now, how can we get this proteinuria measured? Because we need a urine albumin creatinine ratio of 30 milligram per gram to diagnose diabetic kidney disease. Now, let's order a simple urine full report. Okay. What are the plus points of ordering a urine full report? You have got urine pH, which is useful, number of white cells, number of red cells, presence of casts, and presence of protein. Is it good enough? Now, proteins in a UFR comes as trace, 1+, 2+, 3+, and 4+. Now, what is the meaning? To appear a trace in a urine full report, you need at least 200 milligrams of protein in urine. So UFR, my dear friends, is not sensitive enough to pick your diabetic kidney disease because you need 30 milligrams. So don't do a UFR alone. So let's go to the next test. 24-hour urine protein excretion. A wonderful test, but it's so cumbersome. Just imagine you performing this, starting to collect urine from 7 a.m. in the morning up to the 7 a.m. the next day. You can't pee outside. Oh my God, you have to pee to the bottle. And if you drink too much, then there will be variations in the results. If you drink too less, there will be variation in the results. So as practicing nephrologists, we don't like 24 urine protein excretions. Only in specific conditions we will be doing it. So this is not a routine test anymore. So don't ask for it if it is not necessary. The third test, urine microalbumin. Is it rational to ask for urine microalbumin? But all these laboratories in Sri Lanka are not governed by the chemical pathologists, will give a result less than 300 to more than 300. Is it useful? No, because we need to diagnose diabetic kidneys at 30 milligrams of deciliter. What is the point of knowing whether it's less than 300 or more than 300? None of my decisions will depend on just a positive urine microalbumin. Okay, so what is the correct test to do? So you have to ask for, either a urine protein creatinine ratio or a urine albumin creatinine ratio for quantification. So what is the correct test to do? Now there is a huge debate. Now for me, my advice would be for the family physicians to do a urine albumin creatinine ratio, for the nephrologist to do a urine protein creatinine ratio. Hey, this man is nuts. He's making this, audience nuts. So why am I telling that? Urine albumin creatinine ratio catches albumin. Now just think your two kidneys as a sieve where you have 1.5 million sieves. Now with the damage with diabetic kidney disease, the size of the hole of your sieve is getting bigger and bigger, and the smallest protein leaks first, which is albumin. With a kilodalton, it's 60,000 daltons. Now, when it becomes bigger and bigger and bigger, immunoglobulins and the larger proteins start leaking. So for your purposes of catching diabetic kidney disease, what you have to do is albumin creatinine ratio, because you have to be sensitive and get the albumin code first. Don't worry about the proteins. Then the next thing is UACR assay is less complex, and the laboratories are so used to doing UACR more than UPCR. But the problem of nephrologist doing a UACR is you are sending the patient to me to diagnose non-diabetic renal disease. So I should be able to see all the proteins leaking through the kidney. So if it is a myeloma plus diabetes, SLE plus diabetes, I have to see whether there is additional proteins present. So when you send me a patient with a higher UACR, I might do a UPCR. Just don't get disheartened. Continue to do UACR. That's the best test available so far to quantify protein in your urine. Okay, so I'll skip that slide. Now, once again, there's a mythology. There should be proteinuria to diagnose diabetic kidney disease. If there's no proteinuria, for example, one of your patients has got a creatinine of 1.2 after 10 years of diabetes with normal UACR. Is he having diabetic kidney disease? It could very well be. If you look at the data, type 1 diabetes, 25% are non-albuminiuric, and type 2, about 50% are non-albuminiuric, and they don't have diabetic retinopathy, and the progression is less. So once again, we have to come out of the mythology that all patients are having proteinuric diabetic kidney disease. It may not be the case. Okay, now moving back with the study. So her serum creatinine and eGFR was repeated with a urine ACR, and the result came as 290 milligrams per gram. No question, this is above 30, right? That we know. So yes, now we diagnose diabetic kidney disease. Is it good enough? Happy? Treat as diabetic kidney disease? The answer is no, because almost always there could be coexisting non-diabetic renal disease or non-diabetic renal disease alone. So always the nephrologist or the physician looking should have a suspicious eye. Could this be non-diabetic renal disease? Am I missing something here? So that vigilance should be there in any practitioner seeing diabetic patients. So let's look at the features which would alarm or tell you that this is a non-diabetic renal disease. Now, absence of diabetic retinopathy or neuropathy. I know this is the practice. Look for retinopathy, send it to diabetic retinopathy screening. If it is there, yes, it is diabetic kidneys. If it is not there, it's not diabetic kidneys. Once again, it's not a universal truth. It can vary from 15 to 50% patients may not have diabetic retinopathy. So this is not an absolute truth. But for your purposes, in the primary care, if you have diabetic retinopathy and having a proteinuric CKD, you can think of diabetic kidney disease. And if there is other systemic disease like lupus erythematosus or any evidence of myeloma, you have to think of non-diabetic renal disease. If there are active sediments, red blood cells, red blood cell counts, think of non-diabetic renal disease. Massive proteinuria, this is very important. You have to catch these fellows. If there is more than 5-fold rise from the albuminuria last year, now for example, this patient 200 odd, albuminuria goes up to 1000 milligrams in the next year, you have to think of non-diabetic renal disease. Because diabetic kidney disease is a grumbling disease which damages you over many years, not in 1 year or two. And finally, if there is rapid worsening of eGFR, rapid drop of eGFR, you have to think of diabetic kidney disease. Now, this is a very important point. I have seen the doctors managing patients with eGFR dropping by 5, 10, 15 and waiting, but that may not be diabetic kidney disease. If it is diabetic kidney disease, the drop is usually below 5 milliliters per minute. Okay, so much for non-diabetic renal disease. Can I predict the prognosis? Now, patient comes to me and telling there is albuminuria and there is a bit of creatinine rise. Can I tell how long you can keep the kidney for? Use this KDIGO 2012. This picture, if you plot in this, you know there are 5 GFR categories, 3 ACR categories, and you plot it. Our patients was eGFR around 50, albuminuria was 3300, somewhere here. So the color is orange. So she has got a moderately worse prognosis towards advances to end-stage renal disease. But if your patient is in the red zone, things are not looking good. Be careful. Okay, the reason for the lecture, probably why I was invited to discuss this topic. Do I need to refer this patient to a nephrologist? So let me give the 2024, we are in 2023, sorry, this is the draft KDIGO guidelines for the nephrology referral. This is 2024, I'll give you the slides, don't worry about the slides. Now, diagnosis of CKD, if there's a problem about the etiology, for example, if there's a problem about hereditary kidney disease, recurrent nephrolithiasis, or cause of CKD is uncertain, you refer, no questions asked. Then the eGFR criteria, if it is below 30, or if there is rapidly dropping eGFR, you refer, no questions asked. Regarding albuminuria, if the albuminuria more than 300 milligrams, initially in the past we used to call it macroalbuminuria, or if there is rising of albuminuria, you refer. But others, for example, other refractory hypertension, if you are thinking of renal artery stenosis, you refer. But is this good enough? So there was a lot of discussion upon this development. A lot of papers have come up, and as nephrologists, we also discuss and we also look into data. We have major problems with these recommendations and these kind of food for thought. So think, from your physiology days, probably Professor Pujitha used to teach me these things. These graphs probably came from him, don't know. But anyways, for creatinine to rise just above the reference range, you see your eGFR is in the x-axis. Now it to drop from here to here. GFR should drop by 50% for creatinine to rise by 0.1. So for a nephrologist eye, a 0.1 rise in creatinine is a 50% drop in eGFR. Good or not good? Not good. So we are not happy about this eGFR criteria. Let's look at the third. So if you start referring at an eGFR of 30, 70% of the kidney function is lost. What can we do? We can't do anything. Next, do we have enough renal replacement therapy in the developing world? Now these guidelines are developed for USA and UK, probably. But for developing country, just tell me, do you know any patient who gets 3 times a week dialysis, which is the recommended dialysis dose in this country? I have 30,000 CKD patients in Uva province, as well as practicing at NHSL, another good amount of patients. I don't have any. So no patients is getting 3 times a week dialysis. And do you have CAPD? Do you have enough and more transplants? No. So we can't wait to plan renal replacement therapy. No, that is not the ideal thing for a developing world, because we don't have enough renal replacement therapies available in this country. And I should mention the price of a dialysis machine. It was 1.5 million Sri Lankan rupees before the economic crisis, and now it is 3.3 million. And the RO machine, which provides water, was 5 million, now it is 18 million. So, as a kind of advisor to the Ministry of Health, we took the decision not to purchase any dialysis machines for next 2 years. So this is how bad the country is. Just imagine you are pushing the patients towards end stage, and that's a certain death. So this is not going to work. Okay, do this cover non-proteinuric CKD? You wait until the proteinuria appear? No, because there are a certain amount of patients who are non-proteinuric. Fourth, how can we give renoprotective drugs if the referral is at eGFR 30? Because you have to stop, you can't start SGLT2 inhibitors when the eGFR is below 20, which I'm going to tell later, and then MRAs, which I'm going to tell, finerenone and other drugs, which have got renoprotective benefit at eGFR of 30. It's already near 20, so no point in referring. Don't refer. Okay, that's a joke. Anyways, so yeah, in developing countries, do we have an allotted GP network ensuring linear follow-up? This is something I would like to suggest the family physicians to develop a countable GP network and a family physician network for the Ministry of Health. then we can, ask if there's a certain guideline practiced by all of the general practitioners in this country in a linear fashion, then this is a safe referral. Do you get my point? Even for nephrologists, we get loads of defaults. How can we rely on a GP, who has got, patients do not have money, and the easiest way to find money is to sell a kidney these days. Rather than your vehicle, rather than your land, you can sell the kidney. So in a country like ours, how can we rely on a privatized GP system alone? So if it is a government-funded GP system like in UK or US, then we can rely on these referral criteria. And this nice paper is telling what happens. Now, this is a patient progressing towards end-stage renal disease, and if you refer at current guideline, what can we do? We can't do much. If you refer at eGFR of 60, what can we do? We can't do much. So they propose at eGFR of 100. I think it's too much. We have only 32 nephrologists practicing in this country for 22 million patients, so don't refer all the patients. But be vigilant. Pick your patients. I can't give exact guidelines, and the KDIGO guidelines are not going to work for Sri Lanka. That's all I can say. Okay, so now how should I manage these patients? Oh my God, I think I'm running out of time, but I'll go through quickly. It's not going to be the drug alone. It's going to be a comprehensive therapy. Dr. Uditha Bulugahapitiya also told, it's not going to be just drugs alone. So let's see. Maximum RAS blockade. So get your patient losartan, it's not 25 daily, it's 50 BD. Enalapril, it's not 5 milligram BD, it's 20 milligram BD. You see, so we are not giving even the near dose of losartan and all. So, and these trials I'm going to skip, but let's see what happens to this patient. The creatinine goes up by little and patient becomes hyperkalemic. Are you going to stop losartan? That's another major mistake we do. Are we going to stop? No, because there is a thing called permissible AKI. You allow the creatinine to go up because the pathophysiology of ACE inhibitor and ARB do work by dropping GFR and reducing proteinuria by reducing interglomerular pressure. So you can allow a 30% rate of creatinine and potassium up to 6. So at this juncture, what you have to do is you get down the patient in couple of days time and observe the creatinines and all. So make sure you don't stop ACE inhibitor OARB with this simple rise of creatinine or eGFR. Okay, I'm going to skip these things, but one important slide. The options, so once you achieve the maximum RAS blockade, then it's time to add this one, the SGLT2 inhibitor. Once again, you go on adding SGLT2 inhibitors, and the importance of SGLT2 inhibitors are going over time because the importance of this drug is mammoth. And as nephrologists in this country, as the responsible secretary of the College of Nephrology, what are we doing with this drug? With this drug coming into being, our vision of kidney disease has changed. Now our vision is to make dialysis units, make more CAPD available, make more transplants available. So curative sector cannot be expanded anymore with the current economy in this country. What we have to address is prevention. Now these SGLT inhibitors have been proven against cardiovascular risk, against renal progression. So if I can get a SGLT2 inhibitor prescribed in all patients, so we have started discussions in the formulary division to get SGLT2 inhibitors into the government hospitals. So if you see a patient with eGFR over 20, with any HbA1c, independent of need of glucose lowering, level of albuminuria, or level of blood pressure, you have to start a SGLT2 inhibitor. And the final slide is, it's all about, yes, I'll skip all these things. And this slide is the other important thing. So it's a comprehensive work. It's not just ACE inhibitor ARB, it's not just SGLT2 inhibitor, it's not just NMRA receptor antagonist. Get your blood pressure control. No point in giving blood pressure drugs if you can't achieve a blood pressure target of 130/80. If you don't tell your patients to go for a low salt diet, the kidney is going to progress. You have to get your patient to reduce the weight, as Dr. Uditha said, and you have to advise the patient to go for a regular exercise, lipid management, low protein diet, avoid smoking and avoid nephrotoxic. So it comes as a bundle. So as GPs, if you don't practice this felt and rehearse again and again with your patients, the kidney prevalence, CKD prevalence is going to go up from 1 in 10 to 1 in 6 in 2030. I'm sure the nephrologists in this country will be billionaires or probably trillionaires in no time, but you are going to be left with a sick crowd to play around. So please take this message home and start treating your diabetic kidney disease patients seriously and help us prevent this impending crisis in the near future. Thanks for the opportunity. Thank you.
Thank you very much, Dr. Udana Ratnapala. It was a very comprehensive and very clinically relevant presentation on diabetic nephropathy. So since the time is running out, we won't be accommodating any questions.
Right, thank you very much, sir. And with great pleasure, I invite the chairperson to give away the token of appreciation to Dr. Udana Ratnapala, past president, Dr. Ms. Lalanta Senaratne, and Madam Aruni De Silva. And also please pose for the photograph.